Assalamu alaikum, Bismillahirrahmanirrahim. Today we are going to be discussing a very important topic of embryology, which is the development of the pharyngeal apparatus. This is an essential topic whenever we discuss the head and neck development, and our learning objectives for today are: at the end of the session, you should be able to describe the development of the pharyngeal arches and the derivatives of the components of each arch. Also, you should be able to describe the development of pharyngeal pouches and their derivatives, as well as the development of pharyngeal clefts and their derivatives. Also, at the end, we will be discussing the important clinical aspects, including the discussion on the branchial fistula, which are external and internal. Also, we shall correlate the abnormal development of the pharyngeal arches with the craniofacial malformations and syndromes. So let's start by defining the pharyngeal apparatus. Pharyngeal apparatus is a term which includes the pharyngeal arches, pouches, as well as the pharyngeal clefts. The pharyngeal clefts are also commonly called the pharyngeal grooves. So these three components collectively are known as the pharyngeal apparatus. Let's start by discussing the pharyngeal arches. Whenever you look at an embryo in the early stages of development in the intrauterine life, on the external surface of the embryo, you will see in the developing region of the neck, there will be obliquely disposed rounded mesodermal ridges on the side of the head. And these ridges, which have appeared in the head and neck region, they are known as pharyngeal arches. And their appearance is in the 4th and 5th weeks of development. So let's look over here at this photograph of the embryo. If you just follow the red laser pointer, here is the area of the developing neck region. This is the large and prominent head region of the embryo. And this is a 30-day-old embryo. And the rest of the body you can see is curved. And here is the upper limb bud. And if you follow the laser pointer, you can see the lower limb bud. And also you can see over here is the developing heart. The black arrow is pointing towards the region of the pharyngeal arches. So they are present, as you can see, bars of mesodermal ridges, and these are called pharyngeal arches. And between these arches, you can see over here, here is the groove. This is known as the pharyngeal groove. They were used to be called branchial arches, but this terminology has been abandoned. And now if you look at your textbooks in the latest editions, the terminology of pharyngeal has replaced branchial. Okay, so here are some successive stages in the development of the pharyngeal arches. You can see diagrams A, B, and C. And if you look over here in diagram A, here is the developing head and neck region, and the first and second pharyngeal arches are obvious over here. Then in B, you can see these pharyngeal arches as well. And between these pharyngeal arches, if you look over here, are the grooves known as pharyngeal clefts. So by the end of the 4th week, remember, 4 well-defined pairs of pharyngeal arches are visible on the external surface of the embryo. So the 5th and 6th, they are small and they cannot be seen on the surface of the embryo. Regarding pharyngeal arches, important points to keep in mind are that neural crest cells, they are going to migrate into these pharyngeal arches, and then they will contribute to the different skeletal components of the face. Whereas the original mesoderm of the arches, which was derived from unsegmented paraxial mesoderm, will form the musculature of the face and neck. So here is a simple diagram showing us the upper part of the embryo. And you can see this is the head region, and here is the neck region where the pharyngeal arches are labeled 1, 2, 3, 4, and 6. So you can see the numbering of the pharyngeal arches is in a craniocaudal sequence. 1, 2, 3, 4, and 6. There are the 6 pairs of pharyngeal arches. The 5th one regresses, it is not so prominent, and the 4th and 6th, they merge. Also in this diagram, you can see the largest and most prominent arch is the first pharyngeal arch. These arrows are showing the direction of migration of neural crest cells from this area over here, which is the region of the developing brain. If you recall, during the 3rd week of development, the process of neurulation takes place, and during neurulation, as the neural folds, they unite, a population of cells pinches off from the edges of the neural folds. These are the neural crest cells. So these neural crest cells, they are moving from the areas of the hindbrain towards the area of the pharyngeal arches. And like I mentioned before, the neural crest cells, they are going to contribute to the formation of the skeletal components of the pharyngeal arches, whereas the original mesoderm of pharyngeal arches will form the musculature. 5, 7, 9, and 10. These are representing the cranial sensory ganglia, which are going to supply the pharyngeal arches. We'll talk about that further. So the muscular components of each arch have their own cranial nerve. And wherever these muscle cells migrate, remember, they carry the nerve component with them. The special visceral efferent components of these cranial nerves supply the muscles derived from the arches. So every pharyngeal arch has its own specific nerve supply, and that nerve is going to supply the muscles derived from that arch. These muscle cells may migrate to a different destination, but they will carry their nerve supply with them. So here is another simple schematic diagram which is showing us the cranial sensory ganglia, the cranial sensory ganglia, which are supplying the pharyngeal arches. So here I'm pointing towards this 5th, that is trigeminal cranial sensory ganglion. And you know it's got 3 branches, which are ophthalmic, maxillary, and mandibular. The maxillary and mandibular branches of the trigeminal ganglion are supplying the first pharyngeal arch. Then you can see this here is the facial nerve or 7th cranial nerve, and it is supplying the 2nd pharyngeal arch. The 9th cranial nerve, also known as the glossopharyngeal nerve, is supplying the 3rd pharyngeal arch, whereas the 10th cranial nerve, which is the vagus nerve, this is going to supply the 4th and 6th pharyngeal arches. So these are the nerve supply of the pharyngeal arches. Now, looking at another diagram over here, the upper part of the embryo on the external surface, we can see the first pharyngeal arch, which is the largest arch, is actually subdivided into 2 processes. This one over here, you can see the dorsal process is known as the maxillary process, whereas just beneath it, the ventral process is the mandibular process of the first pharyngeal arch. So maxillary nerve will supply the maxillary process, and the mandibular branch of trigeminal nerve will supply the mandibular process of first pharyngeal arch, respectively. Also within this mandibular process appears a cartilage which is known as Meckel's cartilage. This appears temporarily, it will eventually disappear. Then you can see the 2nd pharyngeal arch, which is also known as the hyoid arch, and the 3rd, and so forth. Now, this is a lateral view of the head and neck region of an older fetus, showing us the formation of different skeletal components from the arches. This is a color-coded diagram, so it's easy to understand and remember the derivatives of the arches. Let's look at those parts which are shaded in an orange or brown color. So the orange-brown color is showing us the different parts of the facial skeleton which are derived from the first pharyngeal arch. Over here, you can see this is the maxilla, the zygomatic bone, the squamous part of temporal bone, and also you can see over here this mandible. And also this here is pointing towards the bony ossicles, which are the ear ossicles, the small bones present in the middle ear cavity, the malleus, and the incus. These are all derived from, you can see, the first pharyngeal arch. And the Meckel's cartilage, it appears in the mandibular process of first pharyngeal arch temporarily, and later on it disappears except for a small part dorsally which persists to form the malleus and the incus. The remaining mesenchyme of the mandibular process of first pharyngeal arch forms the mandible bone by membranous ossification. Similarly, these bones, maxilla and zygomatic bone, they appear in the maxillary process of the first pharyngeal arch by membranous ossification. Now let's look at the portion which is colored in blue. These are those parts which are derived from the second pharyngeal arch. So the third bony ossicle in the middle ear cavity, that is the stapes, is derived from the second pharyngeal arch. Also, the styloid process, the styloid ligament, and the upper part of the body of the hyoid bone, these are all derived from the second pharyngeal arch, and it's also known as the hyoid arch. Then you can see the third pharyngeal arch, it forms this small part over here, the yellow portion, which is the lower part of the body of the hyoid bone. Fourth and sixth pharyngeal arches, they have merged, and their mesenchyme over there, you can see it is going to form the laryngeal cartilages. That is the thyroid, cricoid, arytenoids, corniculate, and cuneiform cartilages. Let's move on and look at this similar diagram presented in a little more detail. Over here, this is also a color-coded diagram showing us the derivatives of the pharyngeal arches. The pharyngeal arches are often represented by Roman numerals. So you can see number 1 means this is the first pharyngeal arch, the mandibular process in which the mandible bone has developed, this Meckel's cartilage, which is eventually going to disappear, but its dorsal portion has formed the malleus and the incus. Then comes the blue region, which is showing us the derivatives of this second pharyngeal arch or hyoid arch, the stapes bone, the styloid process, the styloid ligament, lesser horn of hyoid bone, as well as the upper part of the body of hyoid bone. These are all derived from second pharyngeal arch. Then the yellow area is showing the lower part of the body of hyoid bone and the greater horn of the hyoid bone, which are derived from the third pharyngeal arch. Then you can see the fourth and sixth pharyngeal arches, which are forming these cartilages of the larynx. You can see the thyroid cartilage, and you can see this cricoid cartilage. This table is from Langmans Medical Embryology. It is a very good summary of the derivatives of the pharyngeal arches. So if we just quickly go through this table, we are going to see that the mandibular arch with its two processes, maxillary and mandibular processes, its skeletal components are mentioned over here, which I already showed you in the diagrams, the premaxilla, maxilla, part of the temporal bone, Meckel's cartilage, malleus, incus, and also spinomandibular ligament and these other ligaments. Whereas the nerve supply for this arch, is trigeminal nerve, its branches which are maxillary and mandibular divisions. The muscles which are derived from the first pharyngeal arch are the muscles of mastication, that is the chewing muscles, namely temporalis, the pterygoids, and masseter. Also mylohyoid, anterior belly of digastric, and the two tensor muscles, which are tensor palatini and tensor tympani. Let's look at the second pharyngeal arch, which is the hyoid arch. Its skeletal components are stapes, styloid process, the styloid ligament, and the upper part of the hyoid bone with the lesser horn. It is supplied by facial nerve, and this will be supplying these muscles which are derived from hyoid bone, that is the muscles of facial expression, and also posterior belly of digastrate, styloid, and stapedius. The third pharyngeal arch, this forms the greater horn and lower part of body of hyoid bone. Its nerve supplies by the ninth cranial nerve, that is glossopharyngeal nerve, and it is supplying the muscle which is stylopharyngeus. So that's easy to remember because that's one muscle which is going to be formed in the third pharyngeal arch. Fourth to sixth arches, you can see they're forming the laryngeal cartilages. and their nerve supply is by the vagus nerve. Now, vagus nerve has two branches, superior laryngeal branch, which goes specifically to the fourth arch, and recurrent laryngeal branch, which goes to the sixth arch. And the muscles which are supplied by these are superior laryngeal branch supplies cricothyroid, levator palatine, and constrictors of pharynx, whereas the rest of the intrinsic muscles of larynx are supplied by the recurrent laryngeal branch. So you can see the muscles which are derived from the specific arches will be supplied by the respective nerve of that arch. The role of the pharyngeal arches in the formation of the face is essential. The pharyngeal arches contribute not only to the formation of the neck, but also play an important role in formation of the face. So we can see that this area of the cheek and the upper jaw, this part is derived from the maxillary process of first pharyngeal arch, and the lower part of the face, that is the lower jaw and the side of the face, is the part which is derived from the mandibular process of the first pharyngeal arch. Let's just briefly look at the formation of the face regarding the pharyngeal arches. So over here is you can see this is a frontal view of the developing face during early embryonic stages of development. And in the center, there is an opening which is known as the stomodium. This stomodium is surrounded by a few mesenchymal prominences. Cranial to it is the large, massive prominence, which is known as the frontonasal prominence. On either side, lateral to the stomodium, are the maxillary prominences. These are paired. Caudal to the stomodium are the two paired mandibular prominences. And this is in the 24th day. If we look a few days later at day 30 at the human embryo, we can see that these prominences are eventually going to fuse and they will form the different parts of the face. So here is the SEM, that is the scanning electron micrograph. And you can see over here, this is the human embryo at day 30. And right in the middle, this photograph is showing us the stomodium, the central opening, which is surrounded by these prominences. Let's look at it again. The one cranial to the stomodium is the frontonasal prominence, on which the nasal cords will appear. And on lateral sides are the two paired maxillary prominences, and caudally are the two paired mandibular prominences. So face formation is directly associated with the development of the pharyngeal arches. Up till now, we were discussing the pharyngeal arches. Now we're going to talk about the pharyngeal pouches and clefts. Each pharyngeal arch, remember, is the core of mesenchymal tissue, which is covered outside by the ectodermal layer, whereas it is lined internally by the endodermal layer. Now, between the pharyngeal arches on the inner surface are the pouches, and externally between the pharyngeal arches are the clefts. Also, each pharyngeal arch has its own artery, which is known as the otic arch, and it has its own cranial nerve, as we already discussed before. This is the coronal section to the upper part of the embryo. You can see this at the top right corner, that this is the developing head and neck region of the embryo, and this dashed line shows us the level of the slice or section that has been taken. And then you are looking at it from in front. So this is the coronal section. And when you are looking at it from in front, this here is representing, this epithelium line cavity is representing the brain. And then below that, you can see the section has passed through the pharyngeal wall. This is the wall of the foregut, the pharyngeal wall. And on either side, over here, are the paired pharyngeal arches, right? So this is the left side and this is the right, and these are the paired pharyngeal arches. And if we are looking at the coronal section, you can see that externally on the surface, this blue line is representing the ectoderm. And internally, this yellow line is representing the endoderm. And if we look at these arches, we can see that craniocaudally, these are the first, second, third, and fourth, and sixth pharyngeal arches. And the first one you can see is the largest and the most prominent one. And between the first and second pharyngeal arches. This has been labeled for you. It is the pharyngeal cleft or the groove. So these are the pharyngeal clefts externally. They are present between the pharyngeal arches externally, and internally between the pharyngeal arches are the pharyngeal pouches. Pouches are present internally. Here it has been labeled for you. This is the pharyngeal pouch. Okay. And also you can see within each arch, there is an artery, a nerve, and of course, the development of cartilaginous structures is taking place. Let's talk about the pharyngeal clefts first. The 5-week embryo has 4 pharyngeal clefts. And at later stages, remember the second pharyngeal arch overgrows to occlude all the pharyngeal clefts. The first cleft is occluded when the second pharyngeal arch forms the external ear. Keep this in mind that the external ear is formed by the first and second pharyngeal arches. As the second pharyngeal arch overgrows all the other arches, it leads to an occlusion of the pharyngeal clefts. So the external acoustic meatus is formed by invagination of the surface ectoderm from the first pharyngeal arch. Overgrowth of the second pharyngeal arch caudally covers the 3 pharyngeal arches, and also it merges with the epicardial ridge in the lower part of the neck. The third and fourth pharyngeal arches will be covered by the overgrowth of second pharyngeal arch. I'm repeating this because it's an important point. And the remnants of the second, third, and fourth pharyngeal clefts will now form an ectodermal line sinus cavity known as the cervical sinus. This is a temporary cavity. It eventually disappears. It is obliterated. So here is a diagram, which is then again the coronal section through the pharyngeal wall. Here is the pharyngeal wall. And externally, you can see this is the ectoderm, and internally over here is the endoderm. So this pharyngeal wall is showing us over here the foramen cecum. We'll talk about that later. And let's look on the lateral sides of this pharyngeal wall, where are the numbered pharyngeal arches, 1, 2, 3, and 4. So you can see externally the pharyngeal clefts are not visible now because they have disappeared. But temporarily, this sinus line cavity, which is a derivative of those pharyngeal clefts, is formed. It has been labeled cervical sinus, and this will eventually disappear. Let's look at the pharyngeal pouches over here. The pharyngeal pouches 1, 2, 3, 4. The pharyngeal pouches present on the internal surface, lined by endoderm, they give rise to some important structures, and you have to keep in mind those structures which are derivatives of the pharyngeal pouches. So what happens to the first pharyngeal pouch is that it forms a tubotympanic recess. This is a diverticulum, which is known as tubotympanic recess. The distal part of this recess expands and forms a sac-like cavity, which will then become the primitive tympanic cavity or middle ear cavity. Its communication with the pharyngeal wall remains narrow and forms the eustachian or auditory tube. So the derivatives of first pharyngeal pouch are primitive tympanic cavity and auditory tube. Now let's look at what happens to the second pharyngeal pouch. The epithelial lining of second pharyngeal pouch, it proliferates and budding takes place as it penetrates the underlying mesenchyme to form the palatine tonsils. In the 3rd and 5th months of development, this area is invaded by lymphatic tissue, and a part of this pharyngeal pouch, the second pharyngeal pouch, persists to form the tonsillar fossa. When we look at 3rd and 4th pharyngeal pouches, we can see that they have 2 parts, which are the dorsal and ventral wings. So 3rd pharyngeal pouch, here is its dorsal wing and here is the ventral wing. The dorsal and ventral wing will form the inferior parathyroid gland and the thymus gland respectively. Remember, both these glands will eventually disconnect from the wall of the pharynx and they will migrate to their distal site, which is the final location. And similarly, the fourth pharyngeal pouch also has dorsal and ventral wings, which will form superior parathyroid gland and ultimobranchial body, respectively. In further stages of development, the similar coronal section through the wall of the pharynx is giving us a better understanding of the derivatives of pharyngeal pouches. So let's look at this again, that the first pharyngeal pouch is forming the auditory tube and the primitive tympanic cavity. Second pharyngeal pouch is forming the palatine tonsil as well as the tonsillar fossa. And here you can see that the third pharyngeal pouch, from there the inferior parathyroid gland has disconnected and the thymus has also disconnected. The thymus gland is going to move caudally and medially, and it's going to merge with its counterpart, that is the thymus from the other side. And eventually the thymus gland is going to settle in its final position, which is the anterior mediastinum, behind the sternum and in front of the great vessels of the heart. As the thymus moves caudally and medially, it carries the inferior parathyroid gland with it. Inferior parathyroid gland eventually settles posterior to the thyroid gland. So the final position and location of the inferior parathyroid gland is behind the thyroid gland. The fourth pharyngeal pouch, it was giving rise to superior parathyroid gland and ultimobranchial body. These also get disconnected from the wall of the pharynx, and superior parathyroid gland eventually settles posterior to the thyroid gland. So keep this in mind that both the parathyroid glands, they eventually settle down posterior to the thyroid gland embedded within its capsule. That is their final location or destination. The ultimobranchial body, it also travels to the thyroid gland, where it gets incorporated within this gland to form a special population of cells known as parafollicular or C cells. These are the calcitonin secreting cells, and calcitonin is a hormone involved in regulation of blood calcium. Since we're talking about the final destination of these structures, we should take a look at this thyroid gland. Thyroid gland originates from the floor of the pharyngeal wall at a point which is later indicated by a depression known as the foramen cecum. So from this point, which is the foramen cecum, the thyroid gland originates as epithelial proliferation, and then it travels or migrates caudally. And this migration is in front of the hyoid bone and the larynx. Eventually, the thyroid gland settles down in front of the upper part of the trachea in the 7th week of development. Okay, so that is the development of the thyroid gland. Its communication with the foramen cecum or point of origin is by a duct known as thyroglossal duct. This is a temporary structure. Eventually, it disappears. So this is a table which is summarizing the derivatives of pharyngeal pouches taken from Langmans medical embryology. You can see the first is forming middle cavity and eustachian tubes, second palatine tonsils and tonsillar fossa, third is forming inferior parathyroid gland and thymus, and fourth is forming superior parathyroid gland and ultimobranchial body. Now, after having discussed the essential developmental aspects related to the pharyngeal apparatus, now we're going to be talking about the applied aspect. I would like to discuss the fistulae with you, the cervical fistulae. What is a cervical fistula? Fistula is an abnormal communication between two epithelial surfaces. And the branchial fistula are those which are present in the neck region. There are two types of branchial fistula. One is external, the other is internal. They are both related to maldevelopment of the pharyngeal apparatus. External branchial fistulae, their embryological basis is that these occur when the second pharyngeal arch fails to grow caudally over the third and fourth pharyngeal arches, leaving remnants of second, third, and fourth pharyngeal clefts in contact with the surface by a narrow canal. Whereas the internal branchial fistula, which is the less common type, occurs due to rupture of the membrane between second pharyngeal pouch and cleft. And this causes the cervical sinus to communicate internally with the lumen of the pharynx by a small passage or canal, which usually opens in the tonsillar region. So let's look at both these types in these simple diagrams. You can see that this is showing us the lateral side of the neck, and here is the sternocleidomastoid. Anterior to the sternocleidomastoid is usually the opening of the bronchial fistulae. And over here, if you look at diagram A, this is showing us the cervical cyst which has persisted. And this cervical cyst is communicating by the external bronchial fistula. It is communicating with the external surface. And on the right side in diagram C, you can see that the lateral cervical cyst is not communicating externally. Instead, it is communicating internally with the pharyngeal lumen by this internal bronchial fistula, which is opening in the tonsillar fossa. So these are the two types of bronchial fistula. In diagram A is the external bronchial fistula, and in C is the internal bronchial fistula. So these cervical cysts which are formed, these are usually benign and asymptomatic, but they can get massively enlarged during later stages. So in childhood, you can see that the lateral cervical cyst might occupy a large area and it might become prominent, and complication can result due to infection of the cyst. Remember, its location is below the angle of the mandible, but they may develop anywhere along the anterior border of the sternocleidomastoid muscle. Now that we have discussed the fistulae, regarding the clinical manifestations of abnormality in development of pharyngeal arches, we need to know about first arch syndromes. What are first arch syndromes? There is an abnormal development of the components of the first arch. जैसे कि इसमें what will take place? There is a wide range of symptoms, a wide range of signs. There could be abnormalities in the craniofacial region, but because the underlying cause is, remember, an abnormal migration of neural crest cells, therefore other parts of the body can also be affected. There are two main manifestations of first arch syndrome which you need to be familiar with. The first is the Treacher-Collins syndrome, and the other one is the Pierre-Robin sequence. Treacher-Collins syndrome, when we talk about it, keep it in mind, it's a rare autosomal dominant disorder, and the typical or characteristic features are that there is going to be malar hypoplasia. By that we mean the underdeveloped cheekbones, and also the hypoplasia of the mandible and maxilla. There is a cleft palate, the down-slanting palpebral fissures, coloboma of the lower eyelids. Coloboma means that there is a deficiency of tissue over there. Deformities of external ear, abnormalities of the middle ear ossicles that can lead to hearing loss. The underlying cause is mutation in the TCOF1 gene, which is responsible for production of the protein triacyl, which appears to be necessary for proliferation of neural crest cells. The other manifestation of first arch syndrome was Pierre-Robin sequence. This may occur due to genetic or environmental factors. It consists of a typical triad in which first there is an underdeveloped mandible known as micrognathia, which causes the tongue to become posteriorly displaced, that is glossotosis, and the posteriorly displaced tongue prevents the fusion of the palatine shells, causing the cleft palate. Decreased quantity of amniotic fluid within the amniotic cavity can lead to this deformation when the chin is compressed against the chest. So here is an infant suffering from first arch syndrome. You can see here the mandible is underdeveloped and the mouth is also larger than normal, known as macrostomia. And also you can see there is an ear deformity, and in front of the ear, preauricular appendages are present. There is a defect in the region of the cheek between the external ear and the mouth. So these are the visible deformities of the craniofacial region. Another syndrome which we are going to discuss is the Dye-George syndrome. Dye-George syndrome is related to abnormal development of pharyngeal pouches. Most of the cases are due to microdeletion in chromosome 22. There is a failure of differentiation of the third and fourth pharyngeal pouches specifically, and the underlying cause is disruption of neural crest cells, which are going to contribute to all the affected structures. So since third and fourth pharyngeal pouches are undifferentiated, thymus and parathyroid glands fail to develop. And the characteristic features are, because of the failure of development of these third and fourth pharyngeal pouches, there will be hypoparathyroidism. We know that the parathyroid glands, they produce the parathormone, which is involved in regulation of the blood calcium levels. So congenital hypoparathyroidism will cause hypocalcemia, which can lead to seizures. Also, because the thymus gland is underdeveloped, this will affect the immunity and there will increase susceptibility to infections. There is also thyroid hypoplasia, facial dysmorphology, and cardiac anomalies, because we are talking about the neural crest cells being affected. So neural crest cells, contribute to endocardial cushions in the heart region. So cardiac abnormalities may also be there. So this concludes with today's discussion on the pharyngeal apparatus. We talked about the development of pharyngeal arches, clefts, and pouches, and also the important clinical aspects. So I have a few MCQs at the end of this lecture. And MCQ number 1 is, you can see this is a clinical scenario-based MCQ. So a 13-year-old infant is brought to the OPD with complaint of fever and throat pain. On examination, the doctor finds inflamed tonsils along with white patches of pus on the tonsillar bed. So tonsillar bed is derived from, you should know after listening to this lecture that it is derived from the second pharyngeal pouch. That's the correct answer. Here is another clinical scenario-based question. An infant is brought to the ER in a critical condition with severe infection, and on clinical examination, he has a fish-shaped mouth, low-lying ears, and the lab results show hypoparathyroidism with abnormal calcium levels. He is diagnosed with Dye-George syndrome. This condition is developed due to abnormality in which arch? It is the pouches, third and fourth pharyngeal pouches. So remember, Dye-George syndrome, third and fourth pharyngeal pouch abnormality. Then we come to the third clinical-based scenario. Here is a male child brought by his mother to OPD with midfacial and mandibular hypoplasia. And after examination, his mother is told that the child is suffering from Treacher-Collins syndrome. Now, Treacher-Collins, we know, is the mandibular hypoplasia. This is caused by defect in, after discussing the topic that the Treacher-Collins syndrome is a first arch maldevelopment syndrome. Okay, so this concludes with today's topic. We have discussed the pharyngeal apparatus today, and I hope this video was helpful for you, and this presentation covered all the essential aspects of pharyngeal apparatus development. And if you like this video, be sure to follow my YouTube channel. Please like and subscribe to my YouTube channel, AnatomyMentor. You can do that by simply clicking on my picture at the end of this video. Also, you can follow my Facebook page, AnatomyMentor, for further lectures on not just embryology, but also histology, gross anatomy, and neuroanatomy. Thank you and take care. Allah Hafiz.